25 years ago, what was the method of delivery for HRT?
25 years ago, I think, is where a lot of the stigma and the scare and all of that, the fear was really brought in from
that terrible study.
Yeah. And at the time, it was primarily oral, and they were using more.
Oh, this was the horse urine.
Yes, the equine.
Yeah.
It was more derived from animals, and it was similar but not exact, and so they were what we call synthetic.
That's it.
Which is why buzzword around things being bioidentical and stuff like that. That's where all of that came from, right?
Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Today we're sitting down with Shari Patterson, a pharmacist dedicated to women's health, guiding us through the various methods of HRT and offering clear, evidence-based insight so you can approach your hormone health with confidence and intention.
So in today's episode, we have Shari Patterson, who is a pharmacist down here on the island. Yes. Welcome to the show.
Thank you for having me.
Well, thanks for coming on and for talking to us about HRT, the different methods that can be used, the different ways that they can be used. Yes. I find it very, very fascinating for myself, just on my own HRT journey. I'm sure you do as well.
Well, yeah, I hadn't really thought about it until we started really thinking about it and getting the questions together. And then I was like, oh yeah. So I think this can be very interesting.
Yeah.
It's an important conversation.
It is.
For us to have as women.
It is. Yeah. Well, and I think it all started for me when I put my patch on. And
you didn't know where to put it.
No. And then I put it on and I'm like, this is not good.
Yeah.
Where did you put it?
On my butt cheek. And then every time I would sit, it would feel like it was ripping. But then when I would stand, it would like crunch up. But I didn't know really what else to do. So yes, so that was my story. I'll talk a little bit more about that too. Maybe what we'll do first is get you to explain to our listeners what hormone replacement therapy, HRT, means from a pharmacist's perspective, and why does the method of delivery matter?
Okay. So from a pharmacist's perspective, we consider HRT to be a symptom management approach. So a symptom management approach that is designed to replenish falling levels of hormones like estrogen, progestogen, testosterone in women during different phases, perimenopause, menopause, and postmenopause. Instead of using a single drug, it's more of a therapeutic strategy to help alleviate the symptoms like the hot flashes, sleeplessness, the vaginal dryness, and also it helps to protect long-term health. So like the bone density, it helps to keep that in check, and it does have cardiovascular benefit as well.
Yeah, we talked about that. We had a holistic cardiologist on the show too, and that was a big eye-opener as well. So walk us through the main ways that hormones are delivered. So we have a number of different ones, and tell me if I'm missing any. So there's the oral pills, the patches, the gels, the creams, injections. Is injections right?
Yes,
oh, I guess like testosterone.
They're not very popular, but yes, there are a couple injections.
And then pellets.
Yes.
As well. And how does each one of them enter the body?
Okay, great question. So for the orals that everybody is more familiar with, that's your tablets or your capsules. Once you swallow it, it goes into your digestive system. From there, it's absorbed, sent to the liver, it's processed by the liver, and then sent into the bloodstream to go and work. For the transdermals, they basically are all the same. Whether it's the patch, the gel, the cream, you are applying it to the skin, it's being absorbed through the skin, and it enters the blood vessels that way. And then we have the injections in a similar fashion are deposited, whether into the skin, under the skin, or under the muscle or into the muscle to then be absorbed again directly into the bloodstream from there. And then finally, we have the pellets, which is more of like an implant that the doctor will make a small incision and insert it, and it will just stay there, like dissolve.
It's like 3 months or something, or is
3
everyone
to 6
different?
months.
Okay.
Okay. Usually about 3 to 6 months.
And I was told it looks like a little piece of rice.
Yes, just a little. It's just some crystallized hormones, and they make it into just like a grain of rice thereabout with your therapeutic dose, and it's inserted.
Okay.
Usually in the hip or buttock area, it's just put in the layer of fat, and it just stays there and slowly dissolves.
Right. Okay.
That's neat.
Yeah, it is. And I think we are both on different methods, somewhat.
I think
different.
Well,
You're on the patch.
yeah.
I'm on the patch. And then I do the progesterone tablet.
Okay.
And then testosterone gel.
Okay.
Oh, okay.
You're not on the testosterone yet.
Not yet.
No.
I'm hoping that's in my next follow-up.
Yeah.
Because I think I need it. But yeah, I have an IUD, so I don't need the progesterone.
Oh, right. Yeah.
I just get the estrogen in the patch.
Which is another
A whole nother topic.
well.
Yeah.
Yeah.
Yes. So you do need the progesterone, and that actually is it has double benefit, because, for example, women who are perimenopausal and will still get a bleed every now and then, it could be it works as a contraceptive for them, and it still protects the lining of the uterus with the estrogen therapy. So yeah.
Right. Oh,
I know.
so many different things. And I have more questions, and I'm not sure.
Yeah,
if
I think
they're
we'll get to
coming
them,
up.
right? If not, we'll just keep rapid fire.
So how does taking hormones by the mouth differ from absorbing them through the skin in terms of how they're processing in the body? Now, I have kind of some questions with regards to this too, because I've noticed a bit of a difference.
Yes. Okay. So the big difference is that when you take it orally, it does go to the liver, and it goes through what we call first pass effect, or the first pass metabolism, where the liver breaks down a huge chunk of it.
Yeah.
And so because of that, you usually need to start with a bigger dose.
Oh,
so
okay.
that after the liver does break down that chunk of it, then you still have enough for what we call like a therapy that will have therapeutic value. Whereas with the transdermals, initially they don't go straight to the liver. The active hormone gets straight into the bloodstream, and so it gets to go around and get absorbed. So you don't need to start with as big of a dose, just because before it goes to the liver, it will get used because it's already in the main bloodstream. So
I don't know if you'll be able to answer this, but is it fair to say, like, you get a lot of people that will say HRT doesn't work for me, like I tried it didn't work for me. Could this possibly be where a person has maybe some backup in the liver, where they're taking like a progesterone pill or something like that, and it not being absorbed properly because
Or not being a high enough dose.
Yeah.
There's actually like several things that can impact an oral dose. So we can start with the digestive system before we even get to the liver.
Like a person's gut health.
Yes, your gut health.
Yeah.
People with chronic conditions like IBD, IBS, Crohn's would already have a different baseline of absorption than a normal quote unquote person.
So then is it also fair to say that doctors like to go down the route first of the patches because it's quote unquote like maybe a bit safer, like not safer, but it's like more of a sure bet that it will get into the system better?
Well, for each woman, we are going to take everything into consideration. So there's so many things that we're going to take into consideration before we just say the patch is best. Okay. You're right to say that it does bypass a lot of those like initial red flags or biomarkers that a physician would have to screen for to make it more suitable. But some people don't want a patch either, Some people have sensitive skin. So this is where we're going again, where, everything will add up because maybe I have good gut health, but I have sensitive skin.
Right.
you know, so now every time I wear a patch, it irritates me, it's itching, it's red, it leaves a rash and stuff like that. So it's really personalized in every way you can think of.
But also I think I'm only right now realizing that any medication we take first goes through the liver. Mm-hmm. I don't think I noticed that. But I don't think I knew that. Yeah. I mean, no, I don't think I knew that to the point of, wow, like that could potentially have an impact on the liver. Mm-hmm. I mean, I know it's its job, but... And I guess, I mean, this is completely off topic, but
taking ibuprofen.
Yes, this is where I'm, because I've heard like people can get very, very sick or.
Yeah. And so like another thing to consider would be, are you already taking a drug that is probably more.
Like that it'll like interact.
I don't want to say.
Well, no, it's not like more like it's making the liver do a job.
Yeah, so like. I don't want to say it's more important, but what if you're taking something else that is already heavily processed by the liver? Yeah. Or multiple things, because, you know, we're getting up in age. Yeah. And so at that time, we're already having multiple illnesses and multiple factors. So for somebody who is, say, diabetic, hypercholesterol, hypertension, and already taking so many things, you know... considering adding, like, you'll hear people say, I just cannot take another pill.
Right. Right.
I just can't add another pill. And then that's another thing, again, designed by your lifestyle. Right. To say, okay, I'll try the patch, I'll try the cream, because I just can't take another pill.
That makes sense. Actually, maybe I'll ask this one. There's different sizes of patches as well. Like I've seen that people have different sizes of patches. Does it just depend on who made them, or? Yeah,
pretty much.
Is that what it is?
It's just a brand. So I think the bigger ones were like the OGs.
Oh, okay.
I guess.
Okay.
Could be dose too, because I've gone up a dose in mine, and it's slightly bigger. Yeah.
And then they make.
I know.
There's some brands that made it specifically like that's their marketing. Like it's so much smaller than the regular ones, and it's the same dose, same thing. So
do you happen to know, and this isn't a question that we have on here,
it's gonna happen a lot, I think.
25 years ago, what was the method of delivery for HRT?
So I love that you asked that question, because 25 years ago, I think, is where a lot of the stigma and the scare and you know, all of that, the fear was really brought in from
that terrible study.
Yeah. And, you know, at the time, it was primarily oral, and they were using more.
Oh, this was the horse urine.
Yes, the equine.
Yeah.
It was more derived from animals, and it was similar but not exact, and so they were what we call synthetic.
That's it.
Which is why the whole you know, buzzword around things being bioidentical and stuff like that, that's where all of that came from, right? So 25 years ago they were more synthetic, not as similar to the hormones that we have now, which more mimic the ones that you're losing from your body. And that's where a lot of the side effects came from as well, right? Because if it's not identical, then the body kind of still will flag it, you know, as foreign. So I think that's where a lot of the issues came from at that time.
Okay. So it really, like, back then was only just in pill form.
From what I could tell, it was mostly oral stuff.
Yeah. Okay. Now, between the patch, the gel, the pill, and let's even say the pellets, and I know that every woman is different, but are there any signs that you can see that there are commonalities between women that they would see in terms of like differences if they were to take one, like a patch versus a pill?
I think there's several things to consider, like the dosing regimen, so how often you do it, and side effect or the side effect profile, I think, would probably be two of the major ones. So for the pill, you have to take that every day, and you have to try and remember to take it around the same time every day to keep the concentration constant within your body.
And maybe one thing that I should add, and if we kind of go back a little bit, from a pill perspective, should only be a progesterone, right? Not an estrogen.
There are women who take an estrogen.
Is there the estrogen?
Yeah.
Oh, really? Okay. It was just something that I had learned where I feel as though, I don't want to say that it was more harmful or something, but there was more of a risk.
So because of the processing by the liver, and because you have to take a larger dose, the process itself triggers the production of some inflammatory markers that can, in some women, with like family history of like DVT and clotting and stuff like that. That's what I've heard. So it does carry a slightly higher risk than if you were to do the patch. But there are women who still, I think, maybe now most, well, I don't want to speak for them, but from that standpoint, if a woman then has certain red flags, let's call them, that would make a pill not suitable, then of course there's the patch, which we consider safer just because it's not that big of a dose to start with and it doesn't do that first pass effect. So kind of bypasses a lot of those issues.
And then from a cream and a gel perspective, it can be in testosterone form, progesterone form, and estrogen. Okay, so you can kind of do all of them if you wanted to in gels and creams.
Yes.
I will even say, and we talked about this a couple of podcasts ago, that I originally was on the sequential, which for anyone that's listening, it was 2 weeks of just the estrogen, and then in the patch, and then 2 weeks of estrogen and progesterone in the patch, and then I just swap and swap and swap, and I struggled with sleep so badly. I had a twitching eye, my leg even was like twitching, and it put my sleep like very, very light. So and it was only during the second half, which was during the estrogen and the progesterone. And so I rolled that out for about 3 months, gave it an honest effort, and switched over to just the estrogen patch full time, and then 2 weeks of the progesterone pill. It was like night and day. And I have read and been told that the progesterone pill has more of a sedative effect to it. Now, the other thing that I had read as well, and I think it's probably different for everyone, is the progesterone pill acts a little bit more like a diuretic than the progesterone in the patch. So, and I was told that when it's the progesterone in the pill, because it has to go through the stomach, more water gets pushed in, which causes you to basically just pee more. So it's not actually a diuretic, but you just happen to pee a bit more. And oddly enough, I did actually notice that as a difference between the sequential patch and then switching over to the progesterone pill as well.
In some women, it can definitely cause increased urination because of the same method that you explained. And to answer your sleep question, I think with the dosing of the progesterone in the patch and the pill, it's larger. So for some women, if that was not like an issue, I think I watched that episode and you said you were sleeping fine before, and then not so much with
it was almost like I was completely revved up and just couldn't allow my body to just
wind down naturally.
Oh, so you think it's because there was just more progesterone in the patch as a delivery than
in the pill?
Okay.
More in the pill than in the patch. Maybe just needed some more progesterone in the patch. The dose, I don't think, is usually high enough to help with that.
I see. Okay.
And I think even in some women, I read that it starts breaking down in the skin, like before it even gets into into the bloodstream. So
interesting.
Yeah.
So many things.
So
That's
many
why it's so
things.
important to have you on.
And then some women will take the pill and can't take it because they wake up like so foggy the next morning and they feel so drowsy.
Because you sleep like the dead. It's unbelievable how much of a deep sleep that I actually have a client that was like that, and she has to take her progesterone pill like right after dinner instead of right before bed because it carries into the morning for her.
Yes, that's what we normally recommend. Just do it earlier.
Yeah. It's really neat. Okay. Pellets.
Yes.
So this one's a very interesting one.
Yeah.
When someone hears pellets, what exactly does that mean from a pharmacy and medication delivery standpoint? We kind of talked a little bit about it.
Yes. So pellet can actually mean two things in pharmacy and medication delivery. It can be a engineered version of a pill, which is meant to last longer, or it can be the implant like we're talking about now. And so they do compress these crystallized hormones into like as we said, like as small as a grain of rice based on your dose. The doctor will make a little bit of an incision under the skin and just insert it in that area. The only thing with the pellets is once it's in, it's in.
Yeah.
Exactly.
Yeah.
Yes, exactly. And that's what I've heard too, is that like you don't want to start on something like that because if that dose is wrong, you're hooped.
So usually you would want to like know your range or what your dose is before. Or you start lower because you can always add another one if it's not enough. But if you start higher, then you'll just have to write out the symptoms and side effects until it dissolves 3 months later. So it's convenient.
Right.
It's nice to just set it and forget it, kind of. You know, you don't have to remember to take anything or do anything. But then, that would be the only downside.
Are there any differences in how adjustable or flexible each method is of dose? Like no matter whether it's like the patch or the progesterone pill or, you know, obviously like creams and gels, you can pump a little bit more on.
Exactly.
And we know that the pellets you can add a little bit more, you can't take away.
Right.
But with the patch and the pill, is there like different amounts?
Yeah, so the thing with the patch is it comes in standardized strengths. So like your 25, 50, 75, like that. So usually it's flexible in terms of you can just get another one, but then obviously you'd have to speak to your physician, get a new prescription, come back to the pharmacy. Whereas like with a gel or a cream, as you said, you can just do one more pump or one less pump if
I don't think I would trust myself.
I know,
to do
me
it, though.
either.
No, not by yourself. Obviously, you have to like consult with your physician, and you guys decide together. It's not like, no, it's not like still looks a little dry.
Right.
Not quite.
No.
Yeah, it's always a discussion with your physician first.
Okay. Right.
Because sometimes, you know, as you mentioned, like you wrote it out for your 3 months. Like we normally recommend, like give it some time to see where you're at, unless it's like really like no, you know?
Right.
I think just being honest. And then in terms of the pill, same thing, you would have to get a different prescription, come for another strength, and so forth.
And would that be based off of, I don't know if you can answer this one, would it be based off of symptoms or based off of labs?
It could be either. I mean, based on, it depends on the physician's approach. You know, some physicians, especially, you know, if it's experienced, they already know what you're talking about.
Right.
So once you have that conversation with them, like, hey, I'm really not sleeping. It's my third day. Like, what do I do? I'm dying. They will know, you know, how to make that adjustment. Or if it's where you guys were probably making adjustments all along, then maybe they'll be like, oh, let's look at the bloods. I mean, I think annually for most people, or even biannually for some, you retake your bloods and stuff like that to just make sure you're still, because you're getting older. So as you might find a dose that's working right now, and a year from now,
that's what I was
using less. So you always need to check.
Is it fair to say then that most people will always probably have to like go up in strength? Because it's really individual, isn't it?
It really is.
Yeah.
It really, really is.
So I guess maybe how to answer that would just be like, pay attention to your symptoms, be in touch with your doctor, get your labs done once or twice a year. Because I know like people back in Canada, their doctor will give them a prescription and they sometimes won't even see them like for a year when they initially start as well. Yeah, because it's Canada.
Yeah, universal.
Well, I mean, it's great if it's working. That would be great if it's working, because then you're just like, oh, at least I don't have to go for another year. But then if it's not, then you'll have to be like, hey, actually, I feel like, can I come in? Because
that's where I think people are like, this isn't working for me.
Yeah.
I feel like, I feel like crap.
Yeah.
And so I'm just going to chuck it and just say, goodbye
instead of
with it.
maybe asking the doctor if it's worth trying a higher dose.
Yeah.
Or just asking, what are my options? Like, I feel like for us now, even as patients, we really have to, take a lot of initiative on our health. And it's your life, it's your quality of life, and we are literally here to serve you. So we can only go off what you tell us.
Yeah.
So if you took 1 month and you're like, I don't feel great, I'm gonna stop, but then you go to the review in 3 months or 6 months, and then you're telling the doctor, oh, I still don't feel great. So the doctor is calling me and saying, can I up Cynthia's prescription? But Doc, Cynthia only filled the prescription once.
Oh.
Yeah.
Yeah.
We're working off what you tell us. So the doctor is now assuming that you've been on this thing
the whole
for
time.
3 months,
right?
6 months, you're still miserable. We're going up in dose, but you don't really know how you're reacting necessarily to the first regimen that she gave you or he gave you.
Okay. So then how does a doctor or a healthcare provider decide which delivery method for each patient?
So I think the first thing they would look at is the risk profile, because we always want maximum benefit, minimum risk, lowest dose, shortest duration even. So I think that would be the first thing. Do you have a history of breast cancer? Do you have a history of clotting, stroke, DVTs? Are you a smoker? Even like other comorbidities, again, obesity, things like that would probably be the first. And then next, it would probably be lifestyle. If, go to the gym, we're sweating a lot, I sweat a lot, a patch probably wouldn't work for me, because if you're sweating a lot and the heat to the patch, it might change how that sticks. So you might find your patches falling off, or some women naturally have like more oily skin, or what if you're a swimmer, then that would also determine how what you want to start with. So your lifestyle, risk factors, cost. Cost is a big one too. Do you have good insurance that will cover you the entire time, or are you going to run out mid-year?
Lots of things to consider.
Do you have any issues with your patch?
None.
No, I don't either. I had a girlfriend question me about it, and she's like, well, she was just starting. She's like, how do you swim with one? And I was like, this sucker is not coming off.
I know.
Like,
it's crazy. The first time I, opened it, and I was like, this is it? Like this little sticker is going to give me the hormones that I'm needing. Okay. And put it on. And I sauna, I work out, I walk a lot. So I do all these things, and I'm just like, wow, this is so neat. Shower, everything. It's a sticker.
The one thing though that I did notice, I don't know if I talked about this on the last podcast, but there was one time when I was like still sticking it on my butt. It didn't go on properly, so it kind of crinked up, and then so I peeled it back. It doesn't stick again. There is no way.
Can't
so I had
re-stick
to
it.
Yeah. So I learned my lesson too, just leave it and not. I'm more careful with putting it on now, but I definitely learned my lesson. They do not re-stick.
No, I believe that.
Yeah.
While we're talking about the patch, there are different places that we can put them. That is okay, right? Like I do put it on my butt, but more like upper.
Yes.
So I'm not sitting on it. And that's okay.
Yes. So we usually recommend below the waistline. So even lower abdomen, but not in like where your belt or your waist of anything, like with underwear or anything would sit. You can do it on your hips, so like the side of your thighs, upper. And then you can do it on the upper part of your buttocks. Those are the three spaces that we normally recommend you to put it. And of course, rotating it so you don't take off one patch and put it back in the same place.
So this, I do have a question about this too,
Sure.
because you hear that, I hear that, I've heard that from my pharmacist and from the pamphlet thing that you get inside it. But we're changing it twice a week.
Yes.
So I do eventually have to go back to that same place.
Yes, for sure. At least
Just give it a break for a couple days.
At least for a week, you don't use back the same spot. So I mean, even if you're using your lower abdomen, you can go all the way across because it's so small. Same with the butt, you can just put it a little bit, to the side, a little bit further to the side or the next side. Swap.
That's
sides.
okay. Yeah. Okay.
It's just that when you take it off, there's still some. Like in our reservoir,
like residue,
kind of.
or
like in the skin itself.
I see. Okay.
There's still some there, and also it can increase like the risk of irritation. Like you're saying you have to rip it off, and you put it there, you have to rip it off again. You're kind of still damaging like the top layer of the skin, so you just give it a little bit, and that can decrease any irritations that can arise from that.
Okay.
Okay, so then going off of that, testosterone gel, because this just became a topic of conversation on social media recently, about putting it, I can't remember who it was, but she was talking about putting it in your inner thigh. And she was saying that it was like a no-no to do that. I can't remember who it was.
Oh, I don't know
She's
if
like
I saw that one. Like
famous.
an influencer.
Yeah, like
an HRT influencer.
Marie Claire. Mary Claire, whatever.
Right.
But because I was like, because I put mine in my inner thigh for the testosterone. But I think what they were saying is that you just can't go up too high.
Too close to the...
Which I guess you don't want to do.
No.
But how close is too close? Right?
Like an inch, 2 inches?
Yeah, an inch or a foot.
I guess...
I was like, that sounded a bit weird.
Maybe just not entering into like that pelvic crease area. So.
Oh, okay.
Now I'm just okay.
Shoot.
Anyway.
Okay, and then you can also do the
I thought it was like here.
Arms. I think you have to do
like
it
on
inside.
You can do it on the inner. You can do it on the inner or the outer. The thing with the outer is just for people who like have kids and pets and like worry about transfer.
Okay.
Usually just put it on the inner.
Oh, that makes sense.
And it can also go in here as well.
Yeah, so from here to here or out here. Exactly.
It's just like an hour or so that you just don't want to come in contact with like hugging a child or a partner or something like that. So I guess then also like don't go and put your testosterone gel on at night and go and have sex.
Yeah, right.
So obviously it would rub off onto
if you're putting it on your thigh and then
yeah.
And then you want to give it time to dry as well before you even put your clothes on, even if you're not coming in contact with anybody. So the gels typically take maybe about 5 minutes or so.
Okay.
And then the creams take a little bit longer, like maybe 10.
Oh, really? Okay. And why? Do you not want it to come in contact with your clothes?
It'll rub off.
Yeah,
okay,
I see. Dose, yeah.
Okay.
So many questions.
I know. Is there anywhere else that people put the gel or the cream?
It's usually the arms or the thigh. So you can do outer thigh, inner thigh, outer arm, inner arm. That's usually, I think, lower abdomen is still okay if you need. But we usually stick to the thighs and the arms.
Okay. Yeah. I was also told with testosterone that you can grow hair in those places.
You can. Some women can. Some women do.
Like where you put it. Oh, okay.
Yeah. Is that just testosterone? It's not with the...
It's mostly testosterone. Yeah, it's testosterone.
I guess estrogen is not going to make you grow hair.
No, right.
Yeah.
I had also heard that if you take testosterone, you could lose hair on top of your head and grow hair on other parts of your face.
I have heard that.
Have you heard that too?
Yeah. Well, so Not with the taking testosterone, but if you take it and it increases your levels too high, is when you would start to.
Oh, because like you already have some in your body, and then your levels are gonna
just went too high.
Went too high. I see.
Yeah, from a blood perspective.
Right.
Yeah.
We don't know. Jury's still out on that one. Okay. While we're still talking about this, before I move on to something else, so we change, for me, like for the patch, I'm taking the patch. I assume it's similar to like a cream or a gel as well. Change them twice a week.
Yes.
I don't know if this is correct because I didn't ask the pharmacist. Like say if I take it Monday morning, I'll take it again. I'll change it Thursday evening because that's exactly halfway through the week.
Yeah. Well, because there's 7 days, right? So
right,
you have to do
3.5.
One that's 3 and one that's
right.
4. Oh,
I do 3.5.
Yeah, you did tell me that you do 3.5.
Right. So is it okay? Does it matter? Should I be doing 3.5? Is it okay to go 3 and 4? Is it okay to change it up?
So we recommend that you stick with 2 days, the same 2 days.
Yeah.
So the same 3 and 4. Yeah, it's just consistency. You don't have to. I mean, I love that you're thinking about that.
Minute.
Yeah. I love that your brain works that way.
Right down to the minute.
But anytime in the day is fine as long as you stick to the same 2 days.
Okay.
In particular because that reservoir is there. So until you start to get more from the other patch, you still have some from the old patch that's working in the skin. It's just that by the time that runs out, you want to already have the other one on.
I see. Yeah.
There are even once a week patches.
Oh, are there?
So yeah.
What if we forget? Like, what if I take it one Monday and Wednesday, and then or Thursday, and then I forget one Thursday? I'm like, oh man.
You just put it on as soon as you remember. You'll change it as soon as you remember, and then go back to your regular schedule.
Okay.
Don't try to like make a new schedule. Go back to your regular schedule. So if it's just one day, sorry.
Oh, okay.
You still have to just.
I would be then counting 3.5 days later.
No.
Oh yeah, no.
Because then every time
Then
you forget,
everything's
you
I
have a
know.
new regimen,
Yes.
And it would be so like.
And then, so the
Yeah.
same thing for like a progesterone pill. A couple weeks ago, I actually forgot one night before I went to bed, and I didn't remember until like noon the next day, and so I didn't take it because I always take it at night.
Yeah.
But then, like a week later, I woke up at 4 o'clock in the morning. So I would normally take it at 9 or whatever, and I actually. No, it must have even been like 3 in the morning. And then I took it because I knew that it was like just a shorter window.
Right.
But I was like, oh, shoot, I need to be a bit more on this. So I can see where there's those advantages to just having the patch, not having to worry about taking a pill, swapping a patch, putting the gel on, that kind of thing. And I've had people say that, like clients to me say that as well. And so then they were like almost considering going off, and I'm like, if you want to feel the way that you were feeling before, or do you know what, put a notification on your phone to remind you, because you know that it does make you feel good.
That's a good idea, putting a notification on your phone. Because especially like if you are taking something like doing the patch, changing the patch, that's twice you have to remember a week, and maybe you're taking something else too. You have to remember that 2 times a week. You have to remember that every day. You have to. It just ends up getting to be a lot. So
it can.
And take the help where you can get the help. I think
What's that?
Just take the help where you can get the help. So if you need a
100%.
reminder, like,
Yeah.
just do it.
Especially if it does make you feel that much better.
Right.
And you did do the right thing. Closer to when you miss a dose, if it's close to the time for your next dose, you wouldn't bother to take it. But if it's really close to the time that you would have had your dose, then you can go ahead and take it and then just go back to your regular time. And that works with pretty much every...
Yeah.
Now, is this where someone could end up with like breakthrough bleeding or something like that? Maybe, I don't know if it's called breakthrough bleeding, but let's say all of a sudden you went 2 days and you forgot to put the patch on or something like that. Can you have breakthrough bleeding? Like, would it force you to get your period for someone to get that gets their period?
I think that would more happen if you're on like a continuous regimen and then you forget, and you kind of on the sequential, usually it is designed to mimic your own hormone cycle. So if you are going to get a bleed, you would still, the progesterone then wouldn't like cause necessarily a bleed.
Oh, this is actually my other question. We're full of questions.
I know.
Today. someone that has had a hysterectomy that is on HRT would only use the continuous, like one that has estrogen. They wouldn't have one that has progesterone. Is that right, or am I wrong?
So, you're right, except so continuous means like continuous can be estrogen only or estrogen and progesterone all the time.
All the time.
There's some women who do progesterone and estrogen all the time.
Is that someone that still gets their period?
That doesn't.
That doesn't. Okay. Okay.
For the most part, anyways.
Okay.
And then the sequential would be the half estrogen and then half estrogen and progesterone. Yeah. And so women who have had a hysterectomy don't need the progesterone because the progesterone part is really the main thing is to protect the lining of the womb from the thickening that estrogen can cause and so prevent cancers. So if you don't have that, then yes, you don't need it.
What's a partial hysterectomy? What does someone do? Same thing? No, they don't take the ovaries or something with a partial hysterectomy?
If you still have the ovaries, same thing.
Same thing as in
you wouldn't need...
You wouldn't need the progesterone.
Right.
Okay.
Because it's really for the uterine lining.
Got it.
So even if you still have your ovaries, you don't have the lining.
Okay. Okay. Got it.
Yeah.
Okay, let's move on. So the term bioidentical hormones, we hear that out there, not exactly sure what it means. From a pharmacist's lens, what does the term actually mean and what could be some common misconceptions?
Sure. So bioidentical basically means, or now we're calling it body identical as well to see. It basically means the molecule that we're taking is an exact molecular replica of what your body would produce naturally. So a common misconception is that it is more natural.
Yes.
We have the natural form. But to be honest, while we do get it from plants, whether the soy or the wild yams, then it is processed in the lab to get that molecular structure. So it's not necessarily more natural, but it in origin, but it's more natural in terms of it fits the body structure, just like your own hormone that your body would produce.
Right.
I think there's a huge confusion.
Yes. I do too. That. Yeah.
Yes.
Yeah.
And the other misconception is that if you are getting it compounded, it's more bioidentical than, for example, one you would get in the pharmacy. So while we do have some newer synthetic ones in pharmacy, we also do have bioidentical ones. So a lot of the patches, the estrogen that's in it is considered bioidentical or body identical.
Yep.
The benefit though with the compounded ones is that it's specifically made for you, and you can combine things. So instead of having estrogen patch and a progesterone gel and a testosterone, like you could really just pack that into one thing.
Right.
And again, it is meter dosing. So dialing up or dialing down your dose based on your response is also really easy between you and your physician again.
Yeah.
Right.
Yeah.
Right.
So, but we consider them both.
So one of the things that I learned in the program that I was in, is a menopause program, is when we were talking about bioidentical that's made in a compounding pharmacy, you have a risk, correct me if I'm wrong. So let's say they're making a cream or a gel. You do run the risk of, if you are to scoop a bit out or pump a bit on, it may not necessarily be mixed evenly every single time you use it, where if you're getting a non-compounded one, I guess,
like a standardized, it is exact every single time. Is that correct to say? I have also heard the same thing. That's like But it's really, for us, it's just one that's more regulated.
Okay.
Because I do believe that in the lab, as best as possible, you're gonna mix it. You're gonna have, you don't have a regulatory body coming in and testing it, but you're gonna follow all your good operating procedures to keep it as homogeneous as possible, to make sure that,
Okay. So it's not as much of a concern as people are making it out to be.
I wouldn't think so. We're all trained, and even to be a compounding pharmacist, there are programs and there are a lot of considerations that you have to take. There are, as manufacturing processes and stuff that you are following. You have the machinery. Maybe if I do something quick in, to make a little liquid or something in the pharmacy, as opposed to, they have their machines designed, they get everything to really set up their compounding lab, It's not just somebody off on the side. So I think
shaking it, stirring the pot.
Just
a little bit of this, a little bit of that.
Touch. No,
that's actually really good to know.
You're using scales, you're using formulae to really do it the same. So.
Okay.
So compounded formulations is something that the pharmacist does?
Yeah.
Okay. This is news to me. So this is if you, when Nadine was doing the patch, no, because those were different Patches. Sorry. You had the estrogen and progesterone in the patch, but they were different patches for each of that.
Yeah. The first 2 weeks are just estrogen.
Yeah. So that's,
and then the second 2 weeks are estrogen and progesterone in the same
one
patch.
So that's compounded.
No.
Oh.
Yeah. That's manufactured.
Yeah.
So
okay.
That's
compounded would be
biased. I don't know if you've heard of biased.
No.
Or, so compounded would be basically you take your prescription to me. I have the raw materials. The doctor says I want this in an oil base or a cream base or a gel base at this percentage, at this dose. I want each pump to give me this. And I would say, okay, so if I'm going to make Nadine 100 grams of this or 30 grams of this, because she's going to use, let's say I'm going to put her dose in 1 gram. So 30 grams would last her the month. So then I'm going to make a batch. I'm going to work it out, how much powder do I need? How much base do I need? I'm going to put it together, put it in the packaging.
right.
And then I'd give it
So
my label on it and give it. So it wasn't sent to me from the company.
Yes,
It's not
okay.
in a box. It's not pre-packaged from a manufacturing company.
Yeah.
It's me.
Okay.
So compounding can't be a patch. You can't make a patch.
I don't think we do.
No. It would be more just in the
More
form
gels,
of
creams, even the pellets. Before
really?
they had commercially available pellets, compounding pharmacists would
interesting.
make them.
Okay. And so both of these, I guess, wasted the bioidentical hormones are FDA approved. Are they products? I don't.
So the commercial product is FDA approved. The raw material that the compounding pharmacist uses would be FDA or whatever regulatory body approved. But that final batch that I'm giving to Nadine, there's nobody testing.
Right.
Which
Okay.
is what the concern is.
Got it.
But, we're professionals. We were trained to do these things. I don't really feel like I understand that people want to feel, how do you say, secure.
Yeah.
In knowing that somebody else checked this.
Right.
But, yeah.
Yeah, I see now.
Okay.
Yeah.
That helps greatly.
Is there anything women should know about how long the different methods stay active in the body? If they stop or if they change treatment?
Sure. So for pills, just because of that whole first pass and everything, they start losing efficacy.
Yeah.
Almost, not immediately, but a big chunk of the dose is lost there. So and you're taking it every day. So where that is concerned, once you stop taking it or you miss a dose, in probably like a day or two, you'll probably start to see symptoms again. So if you're having the hot flashes and you stop, then they might come back in full force just within a couple of days. For the patches, it usually takes a little bit longer, maybe up to like a week to see. So I mean, your body is actively clearing it, but remember the patches and like the gels, the creams have that little bit of reservoir that's there in your skin still. So it just takes a little bit longer because that's not yet in your bloodstream, right? So once it gets there, then it takes a little bit more time to just process out of your body. Same for, well, not same, but like the pellets, obviously that's gonna be there for months. Yeah. And I think most of the injections are like weekly or bi-weekly. Yeah. So those might take like a couple weeks or so to really fully come out of your system.
From your experience, what are the most common questions or concerns women bring to the pharmacy when they're prescribed HRT?
They probably ask you more questions than they ask the doctor.
Sometimes, some women are like, no, I'm great, good to go. And then some obviously have heard about the study. They're worried about they're just checking again. I told my doctor that I was taking this medication, or, my mom did have, are you sure this is still
just some reassurance. Yeah. Okay.
And then the next would probably be like, where do I put the patch? Yeah. Like, what do I do? Like, we have to tell you when you take it off, fold it into itself so it doesn't stick to anybody else or anything like that.
I stick mine on the next pack because I just rip it open. Oh, yeah. Sure. And I just stick it on the outside of the pack I'm taking the next one from.
Smart. As long as the adhesive is not like, exposed like that. And then next thing is like a lifestyle. So, if the patch is not sticking, then they're gonna, hey, I'm actually having to refill this early because I lost my patch early. Actually, what do I do when my patch falls off early? Great question. I'm gonna segue.
Yeah, that's a good question.
So when your patch falls off early, you put another one on immediately, and then you go back to your regular schedule.
Okay.
And so then we can tell somebody who's that's happening too often, but they want to stay on the patch. We have like I call them sticky wipes. So it's like
I heard. Yes.
Put that on your skin first. It makes your skin more tacky, and then you stick the patch on. Also, some women don't know that when you put the patch on, you should like really leave your hand over it for like a good 10 seconds because the warmth from your body just kind of helps to activate like the adhesive onto your skin. So you can try that too.
I usually do it when I get out of the shower, so my skin's usually still warm, not wet, but still warm. And I have not had any issues with my patch falling off. I have the bigger one. Do you have like the little one? I've seen the little ones on people before.
My first dose was quite tiny. So I was like shocked. Like how does the sticker work? And the second, like now that I've increased a dose slightly, it's a little bit bigger, but it's still not very big.
Another question for you. I just read about it. It's on Instagram.
It must be true.
Is there starting to become a shortage in patches? Can you answer that one?
We have had issues.
I remember in the past,
we have had issues in the past, and it's usually just with that, like there's a main brand that a lot of people are on, but there are generics available that are same dose, same hormone, just from a different company. So I wouldn't like want to worry too much about like.
I feel like it was like a worldwide thing.
Yeah, but it was like mostly, for the most part, just one particular brand.
Is that?
And so, like, if that did happen, we could, like, our pharmacist would probably say to us, "Are you okay getting this different brand?"
And if you want, and if you want to check with your doctor first, that's also sure. But I mean, once it's the same dose, we have authority to just put you from a brand to the generic. Some doctors do have preferences though.
I've seen that actually sometimes on their sheets that they fill out. There's like a checkbox if you want it to swap to generic.
Okay.
Yeah. Okay.
Yeah. Another question is like, will I gain weight?
Yeah.
we always want to know if we can gain weight,
Yeah.
can I drink, you know, stuff like that. And so the recommended, like, for example, for drinking, like, we just stick to the recommended limits for women, which is usually, like, I think 2 small glasses of wine or, like, 1 alcohol unit a day. It doesn't interact. I wouldn't take it, like, at the same time, like, say if you're taking a pill.
Like,
you know, especially for some women, if the estrogen is causing, like, any the oral estrogen is causing, like, any nausea or indigestion or anything like that, you wouldn't want to take alcohol right with that. Or
another thing, sorry,
all right,
that has been brought up by clients before is a client of mine was taking the progesterone tablet and was getting really bad acid reflux, so they swapped it to take it vaginally. Have you heard of them doing that before?
I have.
Like, I guess whether you're getting acid reflux or not, you can take the progesterone tablet vaginally.
Yes.
Yeah.
Yes.
Okay.
So that capsule is actually made for several delivery methods. So you can take it by mouth, you can take it vaginally, or even rectally.
Really?
Wow.
So it just goes into the blood system from there. And the dose is still different. Like if you were taking a patch, it's still the same oral dose, basically, just taken vaginally.
Huh.
Yeah. I know, right?
Very interesting. Yeah.
Yeah. Okay.
If a woman feels unsure or overwhelmed by all of these different options, are there questions that you can recommend that she could be asking her healthcare provider to make a more informed choice?
Sure. I think if someone is feeling like overwhelmed or stressed with this decision, I think the first thing I would recommend her to do is to just make a list of her concerns or any changes that she's observed. And, you know, if you're skeptical, make the list for a little while. And then when you go into the doctor, you're starting from there. You're starting from honesty. You're starting from yourself, because, again, the physician is treating you, the person. You don't necessarily I wouldn't necessarily recommend you to do any research on your own if you're already skeptical. You can, but you might get more overwhelmed with all of the information that you're getting that you probably don't even need because it doesn't apply to you. So you're going to ask about, hey, do I have any risk factors? So you're going to look like, do you think there's any method that's not suitable for me? What do you think is most suitable for me? What if I just want to do supplements first or try nutrition first? Like, what do you recommend? Like, what do you think? You know? I really feel like as women and people, we just have to get comfortable with advocating for ourselves.
Agree.
Yes.
And we're all for that.
Speaking up for ourselves. And, you know, if you go to a physician or any healthcare practitioner, you come to a pharmacist and you don't feel like you were listened to, you don't feel like you were heard, there's so many of us.
Exactly.
Find a new one.
Exactly. There are so many, especially
and that makes you,
especially here. Like I find, like in other places of the world, like maybe in Canada, it's not that easy to find a family doctor. Like you might have your family doctor and it's your family doctor, and to get on a wait list for another family doctor is a whole thing. But at least here, like if
we're so lucky,
we can easily go to a different doctor. Or change pharmacy, go to a different pharmacy. Because there are so many options, and it is literally that easy.
Yeah. It's wonderful. We're very lucky.
We are.
Yeah.
Do you have any more questions for Shari?
I should have came here with my list.
Right?
There's just so many different stories that you hear, and I've had conversations with women over the years of like even them changing to different. So there was a woman that I knew where I ran into her. I usually saw her like a couple times a year, and I had ran into her, and I'm like, wow, she looks different. But I couldn't pinpoint what it was that looked different. She was a spray tan client. And so started tanning her, and then I noticed the little patch on the bum. And so it kind of opened the floor for me being like, oh, I saw that you have like a patch. And she's like, yeah, I was struggling. I think she was like early 50s or mid 50s or something. And I'm like, you know, you look different, but I can't pinpoint what it is. And she's like, you know what? I didn't gain any weight. I didn't lose any weight. She said, but my biggest symptom was that I was so dry. And she's like, and I mean dry everywhere. Even her eyes were dry. And she said because of the HRT, the hydration came back in her whole body. And I'm like, that's what you look like. She just looked really, really good. Yeah. And so then like maybe 9 months went by or something like that, came back, didn't notice the patch. And I had said to her, I was like, oh, did you like stop using the HRT? And she said, no. She goes, I moved over to the pellets. So from her experience, she felt as though it was almost like she couldn't go any higher in like the patch anymore. And so they had to swap her over to the pellet. But I think what happened was there was like some really bad like bleeding. And that's one of the things that I have had some people tell me is that like all of a sudden they're now having bleeding when they never had before. So I don't really know. Is that just because it's not as effective, or like why does a woman start bleeding?
You know, that's a good question. If
like the patch and the pill or the patch on its own was just not enough or not effective anymore?
I don't know if it would be the bigger dose or just the more consistent flow of a dose, because even though the patch is pretty consistent, it's relying on you to change it on and off and so forth. And you know, the pellet is just there and the body just not that it's absorbing too much, but you did mention that she did go on a bigger dose. And you know, sometimes so many little things, different things can
could even just be stress.
It could be anything really. Some people do the IUDs and then they start to get a bleed, you know. So it can be a lot of things, to be honest.
You're right.
What I really wanted to, I think my intention was to just let women know that unless it is your, you know, like we were talking about before, unless it is your decision that you do not want to do hormones and you're just not interested in HRT, sure, great. We're, as we said, we're not trying to like convince you, but if you have been on HRT and you felt like it wasn't working and you feel like your friends are talking about it and they're doing so great and you're not doing so great, and when you tried it, you didn't love it, or, you know, it's just like we want you to know that there are options. There's so many things that between your physician and your pharmacist that you can, you know, try. You don't have to live with the symptoms just because it's a natural part of the aging process or anything like that, you know?
Yeah.
So
I agree.
Yeah. And take your, like, if you're apprehensive, ask questions and take your time and sit with it. And like Nadine and I have said before, we're not trying to say that HRT is the best and that's what everybody should be on. We both happen to be on it, but that's not what this podcast is about. We just want to get the information out there so that people can make the right decisions for themselves. And this was very helpful. Like I would say, if people do have questions or if they're taking a certain HRT, I suppose, talk to their pharmacist if they do have questions, in addition to their doctor, obviously. But this was so great. And we got a lot of our own questions answered today. And yeah, it's great. Thank you so much for coming today.
We appreciate it.
It was a good conversation. Thank you guys.
Good.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!